So I'll talk about strategies used to reduce antibiotic resistance in the ICU. One of the greatest concerns that has emerged in the recent decades is steady escalation in the global resistance against antibiotic among certain strain of bacteria, accompanied by elevating mortality. Around 70,000 people currently die annually because of MDR bacteria, and it will increase to 10 million annually by the year of 2050. So in 2017, World Health Organization published 12 families of bacteria they consider to pose the great threat to the human. It categorized in 3 categories: critical, high, and medium priority, based upon the urgency for need for effective intervention to be developed and put into clinical practice. 6 multi-drug resistant pathogens listed as critical priority are Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacters. Recent example of such organism transition from benign contaminant to a highly lethal pathogen is Acinetobacter baumannii, with increased resistance to carbapenem in 40-60% in some countries, up to 80%. So mortality rates with gram-negative MDR resistant bacteria as high as 80-85%. So we'll talk about strategies that reduce antibiotic resistance in ICU, so preventing drug resistance from developing, and what strategies that prevent spread of antibiotic resistant organism. So strategies already discussed by previous speaker, that antibiotic stewardship and antibiotic de-escalation, then the rapid diagnostic testing, use of biomarker like Procalcitonin for to decide about cessation of antibiotic, new antibiotics recently available, and emerging supplementary antimicrobial therapy. Preventing spread of antibiotic resistant organism like include environmental cleaning, decolonization and source control, proper hand hygiene, isolation, and education. So why MDR bacteria increase in the past decades? Because bacteria innately change over time in response to their environment, whether the environment is within human, animal, or plants. Use a lot of antibiotic in the veterinary and agriculture, increase the changes in bacteria, and this lead to antibiotic resistance. The other main reason is non-judicious use of broad-spectrum antibiotic in ICU patient, and this is like explained by that most of ICU patient all has a life-threatening infection, either whether develop on admission or while they are in the ICU. So other risk factor that increase risk of MDR bacteria in the ICU is the clinical feature related to the patient, like patient has a high severity index and need intervention, ICU acquired type of infection, patient already on antibiotic or antifungal, colonization, which may lead to infection, local epidemiology, and poor practice in the ICU. Antimicrobial stewardship already has been presented by Prof. Jandueli. So it's proven that it decreases antibiotic cost, use and cost, decrease shorter time, reduce incidence of antibiotic-resistant infection without worsening outcome. It's proven that it decreased consumption by 19.1% and typically in ICU by 39.5%. The use of broad-spectrum antibiotic also declined the use of antibiotic by 18.5% for carbapenem, 14.7% for glycopeptide, and overall cost reduced by 33.9%. So a lot of study that already has been discussed and shown that antimicrobial stewardship and antimicrobial de-escalation decrease antimicrobial resistance without changing in the outcome. availability of rapid diagnostic testing can minimize or decrease the risk of MDR bacteria, because we know that the major contributor to the overuse of broad-spectrum antibiotic is the time delay between admission of the ICU patient until the culture result return. And this is because of depend on the conventional method with microbial growth. So this may take like 36 to 70 hours until it's back with the susceptibility. This is advantage that we have susceptibility, but take time. So there is a need for a new diagnostic tool, which is like it's available. The turnaround time between 1 to 8 hours. It's used like detection of the DNA or protein of the bacteria, but again, lack of standardization, expensive, not available all the time. We need really expert microbiologists, and we need people that know what are the limitations of each diagnostic test before depends on using them. So once it's proven that it's decreased antibiotics, and proof will be that reduced development and spread of antibiotic resistance, we need really more rapid diagnostic testing. Procalcitonin has been used to guide and stop antibiotic therapy in ICU patient. It reduced mortality using that with de-escalation of antibiotic, reduced mortality and length of stay, and has been proven in multiple clinical trials and meta-analysis. And as you see, like it decreased the duration and time and consumption of antibiotics in the ICU. And if you see that trials in emergency and intensive care unit, that in favor of using procalcitonin as a guidance for cessation of antibiotic. So all those evidence proving that it helped in antibiotic de-escalation and decrease cost and decrease risk of infection, but it's not already proven that it reduced the incidence of MDR bacteria. New antibiotics in the is available now. Some of them already approved and use, others in phase 3 trial, or use of the old antibiotics, but optimizing pharmacokinetics and pharmacodynamics according to like a lot of factors play in the ICU, like increased volume of distribution with renal impairment. So this all like we need to achieve according to the pharmacokinetics and pharmacodynamics with old or current antibiotics. Supplementary therapies has been available, and we can use in combination with antibiotics like bacteroids, antimicrobial peptides, photodynamic light therapy, and silver nanoparticles. It has been used for to minimize risk of or need for antibiotic, decrease wound healing in dental, skin, and soft tissue infections, but unfortunately, only a few data supporting its effectiveness in humans. Moving now to the strategies that prevent spread of antibiotic resistance, which is environmental cleaning, decolonization and source control, proper hand hygiene, isolation, and education. So environmental cleaning, decolonization, and source control measures are used to decrease spread of infection. And this should be stressed for not only patients, caregiver, nurses, everybody in the hospital. We should pay attention to the all measures or infection control measures to prevent transmission of infection, including personal protective equipment like mask, shield, gloves, gown, and should be used appropriately. Use of antibiotic stewardship compared with the standard of care, plus the 3 measures to decrease spread of infection, which is source control, decolonization. As you see, that it's proven that it's effective compared to the standard of care when it's used all together. So CDC has already published guidelines on how to decontaminate the environment, patients, and healthcare and personnel, and mention this approach. Most of them are really in practice, but we just some area that really need to be cleaned consistently and thoroughly, and we missed most of the time, like cleaning bed ban, toilet area, handhold, doorknobs, light switches, other remote area, which is like a good area for bacteria like Acinetobacter baumannii can be found in the computers, computer keyboards, medical chart, door handles, elevator button, water tabs. So all those should be cleaned appropriately to avoid transmission of resistant organism. The other measures that obviously it's help in prevent or transmission of MDR organism are hand washing. But unfortunately, it's only 40 to 60% compliance to the hand washing. And this is maybe because of time. Like this one study, German study, showed that nurses, usually the recommendation 30 to 40 seconds, but the hand washing by nurses 6.8 seconds, which is 23.3 seconds less than the WHO guideline. And this is because of time constraint. So if the nurse need to wash their hand 200 to 2071 time, which is may need 58 to 70 minutes. This means that in the 12-hour shift, this is really time consuming. So without flexibility and the additional, like putting additional staff and help hand washing will not be appropriately done. Isolation is another method that decreased spread of infection. So either isolate patient with MDR organism or empiric isolation. And the problem that isolation for those patients until identification of organism may take days. So already bacteria has been spread. So that's why the rapid diagnostic testing is mandatory. The other important thing that, or suggestion that not isolating patient only, but isolating their nurses along with hand hygiene and masking and gloving may help reduce the transmission of infection. So the effectiveness of any measure designed to reduce antimicrobial resistance and the spread of resistant organism rely on how well and how consistently they are implemented, and rely on all affected parties being educated in the process, like including healthcare worker, patients, visitors. Everybody in the hospital should should be educated about sticking to the infection control measures. So MDR organism is a global health crisis, and strategies are available. So what we need now is to strict adherence to those practices that have already been documented to be effective, combined with the concerted effort to further develop and test those approaches whose effectiveness remain unknown till now. Thank you very much.